Right now, Dr. Woltering.
For those of you who don't know me, my name's Gene Woltering. I'm from the New Orleans group. And I'm an acquired taste. If you think you have to try caviar a bunch of times to learn to like it, you ain't seen nothing yet. But what we're going to try to talk about today is something that I got to tell you sort of scares the hell out of me. And that is that the goal of all of us, even Dr. Vinnick, is to create a therapy that is personalized for you, works, and, as he pointed out many times, maintains your quality of life. If I keep you alive for 10 years and you're as sick as a schmo, you know about schmoes, sickest mother on earth, if you're a schmo, I haven't done you any great favors. So besides having a therapy that works, you have to look for therapies that keep the patient functioning at a high level. Well, have you ever wondered why, with the accumulated brain power of all the oncologists in the world, that once you develop metastatic disease, nobody cures you? Have you ever wondered why that is? I mean, I can sample a tumor and I can tell you that it has Ki67 chromogranin, Synaptic Aizen, that it has drug resistance testing, angiogenesis testing, etc. And when I get all that stuff done, whether it's breast cancer, colon cancer, pancreas cancer, lung cancer, or neuroendocrine tumor, I can't cure you. And one of the things that we're finding, I hope, is that one of the reasons may be that your primary tumor, the tumor that's in your lymph node, and the tumor that is in your liver aren't identical twins. They're not even fraternal twins. They don't even know one another. And that would be a real problem. Is that true, and is there any data that suggests that? And it turns out that, yes, that data is here, and it's been around since Noah built the ark. This is work by a guy named Dan von Hoff, and I know Dr. von Hoff because he and I were at the NCI from 77 to 79 together. And he's now the director of the Arizona Cancer Institute. And what Dan did was he sampled different areas within the same tumor to see if they were the same, that drug resistance or sensitivity in his case were the same within a given tumor. And then he looked at different tumors from different sites in your body and said, are they the same? And so he looked at 12 pairs of areas in the same primary tumor. For most of you in this room, that would be your small bowel tumor. So he took the small bowel tumor, cut it up into a couple of pieces, and tested piece A and piece B and said, are they the same? Do they behave the same way? And then he took primary tumor versus metastasis, liver or lung or whatever, 29 pairs, and then he tried metastasis in your liver in the right lobe and looked at the liver in the left lobe and said, is that the same? And what you see is that primary versus primary was excellent correlation. But primary compared to the metastasis, the agreement was poor. And it was also poor when you compare the right side of your liver metastasis with the left side of your liver metastasis. Now, what that should do is have everyone in this room quaking in their boots. Because what that says is your very bright doctor, whether he's Gene Woltering, Arthur Vinnick, Tom Odorizio, James Yao, Matt Kolke, can't predict that every tumor in your body will respond to a drug or even a combination of drugs. So that for us to start getting an idea of what we're going to treat you with, we have to analyze more than one site of tumor. Well, sampling a primary tumor in multiple locations is probably not necessary, according to Dr. Van Hoff. Sampling of multiple node metastasis may be critical. So sampling of multiple organ mets, like a liver met, may be critical. And if you only have one met, all sites should be evaluated if practical, not just the primary tumor. So this means that when you have your cytoreductive surgery and we take out your primary tumor, your organ met, and your liver met, it doesn't mean that we should throw all those other things away and just look at one tumor and say, here's the genetic profile or the chromogranin, et cetera. So what we designed was a study that took 14 people. We took out their primary tumors, their lymph nodes, and their liver mets at the same operation, and then we subjected them to a whole bunch of tests. Tests that we talk about all the time: chromogranin stains, Synaptic Aizen stains, Ki67 stains, Angiogenesis testing, drug resistance testing for the tumor, and finally I'm going to share with you today the first time we've gotten genes to tell you, are the genes in your primary tumor the same as the genes in your lymph nodes? Are they the same genes as the stuff in your liver? Because if they're not, now we are really screwed, because genes are what make the proteins, and the proteins are the things like the somatostatin receptors. So if you have a primary tumor that makes somatostatin receptor subtype 2, and a liver that doesn't, and a lymph node that does, now PRRT, gallium scans, et cetera, aren't going to help you, because at the gene level, we don't got the right message in that tumor, or we got too much of the message. Well, our idea has been for a long time that we resect primary tumors, we take out their lymph nodes, and we resect organ metastases. We try to do that in either one stage or in stage 2 or 3 stage things to get you to what's called R0. And R0 is like ground zero. R0 means we've taken you from having 3 pounds of tumor down to having microscopic disease that we can't see or feel. And that's the goal of cytoreductive surgery. It's sort of like the Cinderella principle. As long as you keep dancing with the handsome prince or princess at the ball and you don't turn into a pumpkin, things are okay. And so if I can run in, turn the hands of the clock back to 9 o'clock every time it gets to 11:55, then you keep dancing and things are okay. Well, who wins the chess game? If you've ever played chess, you know that Dr. Woltering is not very good at this. He's not a great chess player. But people who are chess masters, when they play against somebody, you make a move and you're thinking about what move you're going to make next. A chess master, you make a move and he plans 20 steps in advance. So that's what you want in your expert carcinoid or neuroendocrine tumor doc. Don't just tell me that I'm going to go on octreotide. Tell me when octreotide fails what I'm going to do. And when that fails, where am I going to go? So again, a long-term plan with multiple steps along the way, rather than I'm going to do this and then we'll sort of see where we are next time I see you. The plan says you want to pick things that are the most efficacious therapies, but out of a choice of 5, you want to pick the least toxic that's the most efficacious. Again, keeping you alive for 10 years if you can't get out of bed is not a favor to anybody in this room. Well, what do we test? Well, you've heard all these things. Dr. Vinnig's talked about them. Dr. Odorizio is going to talk about them. And these are all important things. Ki67, quantitative stains for chromogranin and Synaptic Aizen. What does that mean? Well, it means that different cells stain with different intensity. So if you have a dark black cell and you have a medium gray cell and a light gray cell, they all stain positive for chromogranin, but it doesn't mean the same thing. The darker the stain, the better the stain. Chemotherapy, we look at drug resistance. We measure drug sensitivity in an angiogenesis assay developed in my lab. And then we ask the question, of all these things, can we give you prognostic factors, and can we make selections for what drugs that you could do? Well, Ki67, the antibody, and this will be a slightly confusing thing. The term MIB and Ki67 are often used interchangeably. The antibody, like like Paris Mamikumian talked about, the antibody that looks for the protein is called the MIB1 antibody. The antigen that it looks for is Ki67. So they're the same thing. So when Dr. Odoricio talks about the MIB1 test, or Dr. Warner talks about the MIB1 test, and I talk about the Ki67, same thing. Quantitative chromogranin and Synaptic Aizen stains, and it's the percent of cells that are dark black, intermediate black, or light black. CD31 and factor VIII are stains that look for blood vessel growth. As Dr. Vinnick said, your tumor can't grow if it doesn't have blood vessels. Think about that. That says that the simple limits of diffusion are about the size of a BB. If you have a tumor the size of a BB and you put it in a mouse or in a human being in a little fat pocket, it can continue to stay alive because it can extract glucose, sugar, oxygen out of the fluid that it surrounds it and excrete its metabolic waste products into that fluid. But if it is a pound, it has to have a blood supply. Only 2 millimeters, the size of a BB, without a new blood supply. Anything less than that or more than that has to have a blood supply. Well, how do we do our assay? It's really simple. We have a little well. We put a piece of your tumor in what's called a fibrin thrombin clot. It's basically a blood clot without blood. And then we overlay it with liquid, and it starts to sprout new blood vessels from the cut edge of your tumor. We ask a couple of very simple questions. Does it begin to grow, yes or no? Black or white? So if you look here, the black wells are yes, the white wells are no. And then we look under the microscope again, and we ask, how much does it grow? Does it grow a little bit, or does it grow a whole lot? And that score goes from 0 if there's no growth to 16. And this gives you an example. This is a piece of tumor, and these are all the blood vessels that grow out of it. The guys in my lab call these the Woltering chia pets. It's not even Christmas. So this is an example of a quarter of this. And you can see these things grow out. They branch like tree branches. They anastomose to one another. And these are real blood vessels. And we've developed a scoring system that works very effectively in our lab. Well, how do we use this for an individual patient? So I take out your primary tumor, I take out your lymph node, and I take out your liver metastasis. And I put it through all of that testing, and then I ask the question, do your tumors know one another? Are they identical twins, fraternal twins, or are they kissing cousins? Well, the first thing we do is we look at the angiogenesis stuff, because this is something that we were very interested in our lab. And this is the percent of wells that begin to grow. So you can see this is a pretty aggressive tumor. These are various drugs that we tested against, and we now have a list of about 20 drugs we tested against. You remember that Dr. Vinnick talked about everolimus, RAD001. Here's RAD001. You'll hear about, maybe I think Dr. O'Dorisio will talk about PTK787, a protein kinase inhibitor, sort of like sunitinib. And here's that drug. Here are things like, this is a chemotherapy called apophyllone B from Novartis. And there are things down here that are being developed in our lab as nutritional supplements like Chinese sweet leaf tea. The red represents how much these things grow, and the blue is a combination of the green stuff plus the red stuff. And so you can see, like here's RAD001. You can look at this versus control and say, hey, that has some effect, but not nearly as much effect as apophyllone B or as Chinese sweet leaf tea in this particular person. We then look at their lymph node metastasis versus their primary versus their liver and then compare the differences. Well, how can we use these kind of tests to help the pharmaceutical industry? Well, we can put your data together with the people over at this table, with the people over at that table, and based on all the information that we got from hundreds and hundreds and hundreds and hundreds of patients, we can do basically a clinical trial in a test tube. We can compare how you do in your control sample versus your drug-treated sample. And so this is the PTK, and you can see each of these represent a control, untreated, and then each dot has a matching treated dot. And this is initiation, or the part that begins to grow, and then you can see growth, overall effect down at the bottom. And you can see that the slope of this line versus the slope of this line, that this drug has a significant decrease in the amount of angiogenesis compared to everybody's control. So this is how they do, if each of these people were an individual that you treated with a drug in the clinic, you'd create these two kinds of curves. Now we're doing the same thing with data from the laboratory. What about primary tumors, nodes, and liver metastasis? Well, we now have 14 patients studied over a 2-year period. They had their primary nodes and metastasis all taken out in one day. And the specimens, we tested a whole bunch of different ways. And again, the question is, are your tumors brothers and sisters, or do they just know one another? Well, this is an important test because same surgeon did the same procedure on the same day. It wasn't one surgery procedure was done in July of 2000 and the next one 2010. These specimens all came out on the same day. The same pathologist read all the slides, and the same technician did all the tests at the same time. So I'm not comparing Quest lab over here to LabCorp over here, to ISI over here, to Joe Schmo's lab or the Mayo Clinic lab. These were all done by the same guy on the same day. That's important. Well, what about the tissue that had the highest percent of beginning to grow? Again, primary tumor, lymph node, and liver met. And as you can see, out of 13 individuals, 7 of them, the highest was the lymph node. What about how much the tissue grow? Well, this is growth. Again, 7 out of 13 had the highest tissue in the lymph node. I would have bet the deed to my house that it would have been the liver metastasis. I would have bet you the deed to the house. And if I had to have a second guess, it would have been the primary tumor, the source of it all. You know, I always kid people, you know, Dr. O'Dorisio, is very religious, and we've been friends for a long time. And I always tell Tom, if I'm ever fortunate enough to get to heaven, I'm convinced that God's going to let me ask him one question. I am. I'm absolutely in my heart convinced that he will let me get the answer to the one question I have all my life. And as you know, my mom had a neuroendocrine tumor. Her primary was this big. Her lymph node was this big. How the hell do you grow a lymph node that big from a primary that big? Why isn't the primary bigger than the lymph node? Well, maybe we're starting to figure that out. Again, the lymph node has more blood vessels per high-powered field. It's more aggressive in its growth. And what about the overall effect? Again, Mr. Lymph Node now in 8 out of 13. And again, we're not just sampling one lymph node. When we do this, we take a big piece of tumor, we mince it up into thousands of pieces so we don't get sampling error. So this is real stuff. And if you look at which tissue's most aggressive, I gotta say I'm surprised, but it's the lymph node. What does this mean? Well, it means that if you have limited tissue and you got to biopsy one thing, I can tell you what we all do. Every person here, we go for the damn liver met. Wrong. We ought to go for a lymph node. We're doing the wrong biopsy, potentially. We ought to be doing the lymph node rather than liver biopsy. And I'm as guilty of it as anybody, based on my previous predisposition, that the liver was worse than the lymph node. What is the Ki67? What does it tell you? It's a stain that uses the MIB1 antibody. It tells you what % of your tumor cells are actively dividing at the time the biopsy was done. This is nice because you can use this, you can get this test done on tissue that's 100 years old in paraffin blocks. And we use this to predict who's going to respond to chemotherapy and how fast your tumor grows. So this is a very important test. And this is my mom. I'm still missing a few stains here, but this is my mom's lymph node. My mom, as the story goes, if you never heard it, is an old nurse. When she was age 90, she was 5 years out from having her mastectomy. And she says, Gene, I got a lymph node in the back of my neck. I feel it. There's no lymph node. I can feel. She says, I'm telling you, there's a lymph node back there. And I'm telling you, Mom, you got a pimple in your hair, you got a little cut, you're nutty in a fruitcake, you're my mom, you're 90 years old, all the doctory kind of things. Next month, she says, the lymph node's still there. Excuse me. And it's bigger. So finally, after 3 months, we took it out. And this is it. And this is the lymph node. And these tumors are called small blue cell tumors. And you can see why. Boy, something got me up here. Anyhow, to make a long story short, we do the Ki67 state. You count 100 cells or 1,000 cells, and what you do is the ones that are black are dividing, the ones that are blue aren't dividing. And this is about 2%. That's what 2% looks like. In close up, you can see that there are cells that stain very, very faintly, but in the Ki67 stain, you only count the really dark ones. So now we're going to compare the nodes to the primary to liver, and for a change, there's good news. They're all the same. So if it was 0 here, it was 1% here. Very little difference in the Ki67 between the primary, the node, and the liver met. That's the good news. Number of patients studied, 13. Maximum variation, 5%. The bottom line, don't need to take stuff and do 50 biopsies for Ki67. One is enough. And since this is stable over time, we're in pretty good shape. Now, what about stains like chromogranin A and Synaptic Aizen? Well, they tell you, they're called differentiation markers. They tell you how much you look like your family. Do you look like your dad? Do you look like your mom? The more you look like family, the better differentiated you are. The implication is that people who look like their family behave better than people who don't look like their family. And this again is my mom's test. This is what's called stromal tissue. This is the stuff that surrounds lymph nodes, and this is the lymph node you just saw. And these are her chromogranin stain. And you can, oh, that might help too. Hey, anybody got any Jack Daniels in the flask? Hey, can't blame a guy for trying. I mean, you know. So I think this cough drop has done the trick. Anyhow, this is mom's stain, and you can see the chromogranin is intensely staining, and essentially every tumor cell lights up. She looks like her family. This is a high-powered view. Again, if you were asking the percent of cells that were black versus light gray versus dark gray, these are all darkly stained. So this would be almost 100% plus 3 stain. And when we did this with the lymph nodes, the primaries, and the liver met, now we're screwed again. Here we go. So this patient, very little difference. This patient here, 10% different. Look here, 70% different. 70% different. No difference. 90% difference. So again, the sampling error thing is a big deal. Same pathologist looking at it on the same day, same technician stained it, and we did multiple sections of each one of these when we looked at them. So what does this say? It says if you're going to do chromogranin stains, you need to do a bunch of slides from a bunch of different sites if you really want it to make a difference. Again, the maximum variation in a given patient is 90%. Now, it had been in other patients, 0%. But it says you need multiple samples done at the same time. Synaptic Aizen, my mom was diagnosed almost 10 years ago before we started doing quantitative Synaptic Aizen, so I can't show you that. And we did somatostatin receptor subtype 2 staining, and I can't show you that. But I can talk about the Synaptic Aizen staining that we did in our study. And again, you have this patient who's 20% stained intensively, 30, 30. So you got 10%, 30% different, 70% different, 60%, 95% different, 80%, and the average is about 40% different. What does that say? You need to do multiple tests from the same tumor. What about factor VIII and CD31 stains? Well, this is something that we do that probably not very many other docs do. And this is, we stain for the number of blood vessels that are feeding your tumor. The more blood vessels, the worse it is. And the report will be in things like number of blood vessels per high power field. Again, some good news and bad news. In a lot of patients, there's very little difference. But in some patients, There are 60% difference. Here you have the primary that has very low blood vessels. The lymph node, again, hello, lymph node, again, the worst of the case, 80, and the liver is halfway between. Again, you have something down here, primary lymph node, liver. This is a pretty aggressive tumor, whereas up here, you have a fairly easygoing tumor. What about CD31? Same kind of thing, and basically a little bit tighter numbers, but still some that have a great degree of variability. Well, what about when you do things like our angiogenesis assay? Agents that can decrease the angiogenesis by 50% or more. And you look at some things like gallic acid, and this is a food preservative that in the 1950s was in everybody's Kraft mayonnaise. They then found a cheaper version called benzoic acid. If you look on your Coca-Colas on the back, benzoic acid, the brother of gallic acid, is now used as a food preservative. Other things like 2-methoxyestradiol, Avastin, black raspberry, you can see there are very few things that worked in 3 out of 3 tissues. Sweet leaf tea. Here's PTK, the sutinib-like drug, in half, basically 7 out of 13. Here is apothelone, 11 out of 92. This makes you sick. This doesn't make you sick. Chinese sweet leaf tea we're working on, it just tastes like dog dew, so whether or not it makes you sick is of no consequence because nobody's going to drink it. What about when you look at sending off things for drug resistance testing? Again, look at how few out of 14 people, or 13 people, excuse me, did 3 out of 3 tissues respond to 5-FU. 2 out of 13. All of them responded. A lot of them, none of them did, or just 1 out of 3 tissues responded. Again, what does this say? It says that if I treat you with chemotherapy and I have 100% response, i.e. low resistance in the lymph node and high resistance in your primary, I kill your lymph node and your primary comes back and kills you. Game over. But if I don't look at this, I'll never know that maybe what I have to do is design 3 different therapies. 1 for your primary, 1 for your lymph node, and 1 for your metastases. And they may not be the same. Well, what about when you put all this together? It appears that for the vast majority of people, the most accurate way to do this is sample a lot of tumors. The pathologists have an old statement, and you won't quite get it until you think about it a second. The accuracy of diagnosis is proportional to the amount of meat on glass. So the more of you they sample and put it on glass microscope slides, the more accurate the diagnosis. And I believe that's true. One size does not fit all. What about putting it all together? Remember Dr. Vinnick was talking about progression-free survival and overall survival. And we've just updated this. It's not done yet, but this is on 185 people. that we did cytoreductive surgery. And as you can see, this is that group that had more than one surgery. As Cinderella, as they start to dance, every time they start to grow, we try to do something to cytoreduce them. And as you can see, almost an 80% 10-year survival and almost an 80% 20-year survival in that group. This is not just surgery. This is surgery plus PTK plus RAD plus PRRT plus everything that we have to do to keep somebody alive. But what it says is, if you look at the information on what the biopsies tell you, if you do drug resistance testing, if you do angiogenesis testing, you can keep people alive with metastatic disease a very long period of time. Well, while I'm a surgeon, and my bias is that surgery takes stuff out, and once it's done and in formalin, it doesn't hurt you, there are lots of other new novel things that we've done in the last decade that have increased survival. Valproic acid, Dr. Chen at Wisconsin, this is an anti-seizure medication. Again, very well tolerated and a superb drug in our assay. PTK and Sutent, the protein kinase inhibitors, RAD001, the mTOR inhibitor, are pathway-directed drugs. I'm about to show you in about 2 minutes that we're going to be able to tell you in the next year, for $2,000, every gene that's related to every pathway and every one of your tumors. High-dose octreotide, lanreotide, PRRT, better biomarkers, what Paris was talking about, what Dr. Vinnick was talking about. The work done by Dr. Ardell that says, if you're if you're a midgut, ileum, or jejunum, and if your neurokinin is over 55, you're dead man walking. 87% chance that you'll be dead in 2 years. If we can treat you effectively and bring you back under 55, it was like you were never there. You now have a 13% chance of dying in the next 2 years. So one blood test may quantitate for that group, special group of people who needs aggressive therapy and who can sort of slide a while. What's new in our lab? Genes. And I'm going to show you now for the very first time, you're the very first group ever to see this, from our lab, primary tumors, lymph node tumors, and liver mets, all the somatostatin receptor genes, type 1, type 2, type 3, type 4, type 5, and this is what I hope you take home, is that the reason that we all thought your primary didn't show up was it was too small, octreotide wasn't good enough, you needed to go to Europe and get gallium-68, et cetera, et cetera. What I'm going to show you is genes are the bottom of the hill. If you don't have the gene, you can't make the protein, and if you don't have the protein receptor, you can't have a positive scan. So if the gene doesn't exist, 5,200 gallium scans, no matter how good they are, aren't going to find something that doesn't exist. And this is hard. I'm sorry, I couldn't get it all on here any other way. What you're looking for are things that are bold and in italics. That means that what we've done in our lab, which we've figured out a way at a gene level to subtract the normal tissue gene, i.e. small bowel from small bowel tumor, lymph node from lymph node tumor, normal liver from liver tumor. So we get rid of all the normal genes and only look at the tumor genes. Okay, so here, patient number 1, somatostatin receptor 2, Nope. Yep. Yep. So the lymph node has the receptor, the liver has the receptor, but at a gene level, the primary doesn't have the receptor. How can that be? That's question number 2 for God. Here's patient number 2. Again, let's look at somatostatin receptor subtype 2. The thing that the gallium-68 scan, the thing that PRRT, the thing that Octrea scan goes after and keys on. Yep, it's in the primary. Oh, no, not in the lymph node. And, oh, yeah, there it is, in the liver. So I just missed all the lymph nodes. But I saw the primary, aren't I proud of myself? And I saw the liver, aren't I proud of myself? And now I wonder why on CAT scan the damn lymph nodes continue to grow when I put you on octreotide, but your liver and your primary stay stable. Well, it's because you don't have the genes there. But look, you have the genes for somatostatin receptor 4 and 5, but notice there's a minus in front of them. Not only do you not have them, they're actually downregulated. You have fewer gene copies than normal. Patient number 3. Here we go. Primary tumor has somatostatin receptor. Oh, no. Here we go again. Lymph node doesn't have. Liver does have. Again, it's the damn lymph nodes that you got to watch out for. The lymph nodes are the bad guys. And so here's patient number 4. Upregulated in the primary. Hello. None in the lymph node and upregulated in the liver. Once it's happening. Twice it's a coincidence. 3 times it's not a coincidence. And when I report this to you next year or the year after, I'll have dozens of people that we've done this to. But the take-home message seems to be over and over and over again. For God's sakes, get rid of those lymph nodes. Don't let your mesenteric mass sit there, because that may be the most aggressive part of your disease. Make sure that when your surgeon goes after your primary that he takes out those mets as well. Well, how do we know that the differences in gene expression are not due to sampling error? This is the most common thing that could happen, is we took one lymph node, we took one liver specimen, and we took one piece of the primary. Well, for each tumor site, 3 different biopsy sites. So in the primary tumor, that big, we took 3 different sites, and each of those 3 sites became 3 tests on a chip. So I sampled each tumor 9 times to make sure that it wasn't a sampling error. In 1 year, I predict my lab for $2,000 will be able to tell you every gene in your primary lymph node and liver met at 38,000 to 100,000 different genes. $2,000. It's going to revolutionize, I think, how we look at pathways. If you don't got the gene for mTOR or you don't got the gene for c-KIT, then we're not going to use drugs that are directed at those genes. We think that the only way we're going to make progress in this disease is if we understand it. The government is not helping us do research. We have to support the people who are doing research, or 10 years from now, we're going to be as dumb as we are now. The Komen Foundation has figured out how to do this. They run races for the cure, etc. Those are fast-growing cancers. We got a new mascot, guys. We got a slow-growing cancer. We got the snail. Thank you very much.